Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th annual conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Oh, thank you, Debbie. It is wonderful to be with you again for this exciting session. So this session is entitled Mental and Behavioral Health, Understanding Service Use and Spending Trends. It was organized by Sara Hallvik and Emily Sim, and today's moderator will be Sara Hallvik. So let's go ahead and bring Sara onto the stage. Sara, it's good to see you.
Good to see you too, Norm.
All right, the stage is yours.
Great, thank you, and hello everybody. Thank you for joining this session. I'm Sara Hallvik. I serve as a NAHDO board member right now, and I'm also the Vice President of Data Solutions here at Comagine Health. I am honored to serve as the moderator for this session about mental and behavioral health, understanding service use and spending trends, a topic that touches all of us in some way, shape, or form. So we are going to kick this off before we go to the first presentation with a little poll. So if you go to the polling tab in the top right of your screen, you'll see a question. So as we get started, I'm curious if you have worked with behavioral health claims data before. That context is going to be helpful for our presenters as we get to some of the Q&A and helpful as we get into discussion at the end. So while you take a moment to answer that poll, I will introduce our first presentation. So our first presentation is understanding mental health service use among people with employer-sponsored insurance from our friends at the Healthcare Cost Institute. Take it away.
Hello, everyone. My name is Bianca Silva Gordon, and I'm a senior researcher at the Healthcare Cost Institute. My presentation today is on understanding mental health service use among people with employer-sponsored insurance. On my screen is an outline of what I will cover in this presentation, beginning with the policy context that inform this analysis, followed by the research questions, study design and methods, results, and takeaways. And with that, I'll dive right in. Federal law passed under the ACA and Mental Health Parity Act mandated that insurers cover mental health services and not impose limits on benefits that were different from other medical benefits. These laws increased access to mental health services for people with health insurance. Then beginning in 2020, the COVID pandemic and coinciding periods of isolation exacerbated what was already a trend of increasing prevalence of mental illnesses, especially anxiety and depression. Demand for mental health services increased during this time, and data from our previous studies show that as of 2022, use of mental health services remained elevated following the initial months of COVID compared to previous years. It appears that there's been a longer lasting effect of the pandemic on mental health. Given the current high demand for mental health services and the understanding that access to mental health services is essential to a healthy population, we wanted to understand whether and how people with employer-sponsored insurance, who I'll refer to from here on out as the ESI population, are using their mental health benefits. And the good news is we can use claims data to find out. In our study, we sought to answer 3 research questions. What mental health services are people with ESI receiving through their insurance? How much are people with ESI spending on these services? And do we observe changes in use or spending on these services from 2018 to 2022? These questions were purposely broad and descriptive as we're looking to paint a picture of the mental health landscape in broad strokes, as there isn't much foundational research like this that exists. To answer these questions, we designed our study as a descriptive study using the Healthcare Cost Institute's de-identified commercial claims data set. Our analysis was conducted at a national level for the years 2018 through 2022. In the next 2 slides, I want to get into a little bit of the nitty-gritty of how we did this analysis to show that it is replicable and can be done with virtually any claims data set. The first step is to do some basic data cleaning. Claims data are real-life data, and they're like receipts for healthcare services. And like any real-life data, they can be a little messy, so data cleaning is an important step to make sure we're capturing the correct people and services in our analysis. For our analysis, we removed claims where beneficiaries were not enrolled in an ESI plan with mental health coverage, where beneficiaries were age 65 and older at the time of the service, indicating they would probably qualify for Medicare. And we also removed claims not paid for by primary insurance, so for example, by a workers' compensation plan. We also removed claims with an allowed amount less than or equal to $0, which would indicate a claim denial or reversal. And we removed any professional claims that occurred during an inpatient stay. And I'll get into that a little bit more later, but we removed these claims because the focus of the study was really on non-acute mental health services. The second step is to identify and restrict claims to those rendered by a mental health provider. This is a key step because without being able to identify the provider's specialty, it's very difficult to know which services were mental health services. For example, evaluation and management visits are a very common type of code that are used across different specialties. So we really wanted to narrow those down to those that were provided by mental health professionals. We use the National Plan and Provider Enumeration System, also known as NPES, to join the provider's specialty to each claim on the National Provider Identifier. Once data had been cleaned and provider specialties had been joined to claims, the third step was to categorize the services of interest and the provider types. We used HCPCS codes to categorize services into 4 broad buckets: therapy, evaluation and management, behavioral health assessments, and all other services. And then we use the provider classification groups from NPES to determine the provider types. So for example, social workers, psychologists, nurse practitioners, etc. The final step was to aggregate counts of use and average total and out-of-pocket spending. So for each provider type and service, we generated a count of unique patient and service date combinations to give a sense of the volume of services rendered. And we summarized allowed and out-of-pocket amounts as the total and out-of-pocket spending respectively. Before displaying the results, I want to point out a few limitations to this study. The first is that we only capture mental health services for which there is a claim. It's well known that many mental health services are self-paid outside of health insurance, sometimes due to a patient's preference or an inability to find an in-network provider. Therefore, we are not capturing the entire universe of mental health use, but rather the mental health services that are paid for by employer-sponsored insurance. The second is that this analysis is limited to a subset of non-acute, non-facility services, meaning hospitalizations at inpatient psychiatric hospitals or rehab facilities are not included. This was an intentional decision as our focus for the study was the use and spending on non-acute, ambulatory type mental health services, which by and large are the most commonly used mental health services in the ESI population. And finally, I want to point out that the claims dataset we used is a convenient sample that contains about 1/3 of the ESI population. In the next few slides, I will review the results from our study. Our first observation is that the use of mental health services increased from 2018 to 2022. As a proportion of total professional claims, mental health claims made up a larger share by about 2 percentage points from 2018 to 2022. This increase in mental health claims was driven by both an increase in the number of patients using services and the number of services being used per patient. The proportion of ESI enrollees who received a mental health service increased by a little under 2 percentage points from 2018 to 2022, and the rate of mental health service use per 1,000 ESI enrollees increased from 532 to 858, or a 61% increase. We learned that therapy was the primary office-based mental health service used across all the years we studied. In 2022, therapy accounted for over 3/4 of all mental health services used, followed by evaluation and management visits at 13% and behavior health assessments at just under 6%. The rest of the services made up less than 3% of mental health service use. Our data also showed that allied professionals delivered the majority of these mental health services. Counselors and social workers combined provided just under half of all mental health services, while psychologists and psychiatrists provided just under 30% of services. In our final analysis, we looked at spending on therapy services, which comprise the largest share of mental health services rendered. We found that spending on therapy services has increased over time, with an average total per patient spending increasing by $764 from 2018 to 2022, and out-of-pocket spending increasing by $87 per patient. This increase was driven by both an increase in the number of services used per person and an increase in the average price of therapy services. Over the study period, the average number of therapy visits per therapy patient increased from 10 to 13, and the average price of a 60-minute psychotherapy session, which was the most commonly used therapy service, increased from $114 to $125, which represents a little over a 9% increase. Overall, we learned a lot about the mental health landscape among those with employer-sponsored insurance from this descriptive study. The key takeaways I reviewed are listed on the screen, and I want to highlight the last bullet point, which is that this analysis is replicable on any claims dataset that has the provider, NPI, and allowed amount information available. There are opportunities to further stratify an analysis like this by geography, including by state, county, CVSA, even zip code if that information is available, as well as place of service, and to identify mental health use within specific populations. That brings me to my last slide. I'm happy to connect with anyone to discuss methodology or any other questions related to this analysis. My contact information is up on the screen. Thank you all for your time.
Thanks, Bianca. That was a great overview and really interesting information you shared. Audience, if you have any questions for Bianca, please go ahead and put them in chat now. And I'll just kick one off, which was there anything in your work that surprised you? Were you surprised by the results at all?
Yeah, I would say I wasn't really surprised by the increase in mental health use, just given kind of what I know anecdotally about kind of the increase in the prevalence of mental illness and kind of the acceleration of that after COVID. I would say the thing I was surprised by was that the majority or a good proportion of mental health services are being rendered by allied health professionals. So kind of less by psychiatrists and psychologists, which is kind of what I was expecting. But I think that's kind of interesting. I'm interested to kind of dig into that more in the future, but I think it could point to maybe a couple of things. One, it might indicate a shortage of psychiatrists and psychologists. So there's other allied professionals kind of stepping in to fill that gap. And it could also be kind of a function of that could be that the costs of therapy services are actually lower than maybe they would be if it was provided by professionals, by psychiatrists and psychologists that might command a higher rate for those services.
Yeah, that's a really interesting thing, especially as we think about workforce shortages and workforce development across all fields, but especially in behavioral health. So, and I love the call out that your work is replicable on any all-payer claims database or any claims database. So for those of you listening who may be interested in testing whether this is true in your geography as well, I think you have a nice model to follow here. Another follow-up question for you is, could you say a little bit more about the variety of services that people are receiving? Did you dig into the specific types of behavioral health services?
Yeah, so the way we did it was we kind of looked at what the data was showing us and then created categories based on what we were seeing. So we didn't restrict by service. We just kind of categorized, we grouped the services we were seeing into the buckets of therapy, evaluation management, behavioral health assessments, and then everything else kind of fell into that small other bucket, which made up like less than 3% of total services. And yeah, I mean, I could at some point, if someone was interested, I'm happy to share the specific like HCPCS codes that we used, but it was very basic, like basically matching on a set of codes to group those.
Thank you. And maybe just one more question before we go on to the next presentation. Question from Chris, thank you. Did you or could you look at all of the prescription rates for common mental health medication? For example, Lexapro, SSRIs, Adderall, et cetera. Wondering if this could corroborate or tell a deeper story.
Yeah, so that's one thing that's definitely absent from this analysis. It's something we're looking to do, that we're working on right now for a follow-up study. But I think that is an important part of the story. Obviously, that's a big part of mental health treatment, is prescription medication. So I think that is also possible with claims data if you have your pharmaceutical claims. And yeah, I'm happy to like talk about that more, maybe offline. But yeah.
Great. And if any of you have experience in any of these areas, please go ahead and share that in chat too. All right, I think we'll move us on to our second presenter. So thank you, Bianca, again, for sharing your wisdom with us. I'm pleased now to present a second presentation called Behavioral Health Spending in California's Commercial Market from 2018 to 2023, presented by the California Department of Healthcare Access and Information. Take it away.
Hello, everyone. I'm Debbie Lindes, Healthcare Delivery System Group Manager at the California Department of Healthcare Access and Information's Office of Healthcare Affordability, which we refer to as HCI and OCA. My colleague Ertug Misirli and I will share with you the results of HCI's analysis of commercial behavioral health spending from 2018 to 2023 using data from California's All-Payer Claims Database, the Healthcare Payments Data System, or HPD. This analysis has been instrumental in shaping HCI policy for measuring and benchmarking behavioral health spending in California. I'll start with some background. We know that mental illness and substance use disorders are common, and there's been increased attention in recent years to the need for better access to behavioral health services. California has launched several initiatives to address this issue. But despite this policy focus, California lacks publicly available data on behavioral health spending. OCA is charged with measuring behavioral health spending as a percentage of total healthcare expenditures and with setting benchmarks for behavioral health investment. This analysis of data from HCI's HPD contributes to filling that data gap and supports OCA's work. To conduct its analysis of behavioral health spending, HCI's HPD team analyzed commercial claims data for 2018 through 2023 behavioral health spending using a standardized methodology published in 2024 by the Milbank Memorial Fund. This analysis gives HCI insight into baseline behavioral health spending, including both mental health and substance use disorder spending, as HCI moves toward measuring and benchmarking behavioral health investment. I'll note that this analysis excludes non-claims payments such as capitation. Additional limitations of HPD are its exclusion of plans with fewer than 40,000 members and certain public health insurance programs. Self-funded employer plans regulated under the Employee Retirement Income Security Act, or ERISA, are voluntary rather than mandatory submitters to HPD. This is a schematic representation of how a claim is identified as behavioral health spending using the Milbank methodology. The first and main test is whether the claim includes a behavioral health diagnosis as its primary diagnosis. The exception to this is when the claim is for screening or assessment for a mental health condition or substance use disorder, which does not require a primary behavioral health diagnosis. The service subcategories in the center of the diagram are defined by place of service, revenue, and service codes. Once a claim is determined to have a primary behavioral health diagnosis, this further categorization has no bearing on the claim being included as behavioral health spending and is only used for analysis and reporting. Pharmacy claims are separately determined to be behavioral health spending based on national drug codes, or NDCs. And finally, all claims can be identified as for either mental health or a substance use disorder using the primary diagnosis, allowing separate reporting of each. And now I will turn it over to Ertug to review the results of HCI's analysis.
Thank you, Debbie. Hello, everyone. My name is Ertug Misirli. I am the Research Data Specialist within the California Department of Healthcare Access and Information, and I'll be going over the behavioral health spending analysis and highlighting key findings. This slide here shows mental health and substance use disorder spending as a share of total commercial claim spending from 2018 to 2023. The orange bars represent substance use disorder spending, blue bars represent mental health spending, and boxes above the bars represent total behavioral health spending as a share of total commercial claims spending. In 2023, behavioral health spending made up 8.2% of total commercial claims payments, and as you can see in the chart, its share of spending has been increasing steadily throughout this time period. Our findings also show that a much larger proportion of behavioral health spending is allocated to mental health services compared to substance use disorder treatment. And during the period of this analysis, close to 90% of total behavioral health spending was for mental health services. The next slide, here we see the spending levels in dollars for both mental health and substance use disorder. Looking at these values makes it clear how each contributes to total behavioral health spending. And overall total behavioral health spending increased about $2 billion, or in percentages 65%, from 2018 to 2023. Mental health spending increased about 63%, and substance use disorder spending increased about 80% from 2018 to 2023. Here is a table that breaks down commercial behavioral health spending by subcategories, showing each as a percentage of total behavioral health spending over the same period. We see some shifts over the 6 years of the analysis in the distribution of spending across subcategories, with an increase in share of spending going to outpatient, professional, non-primary care, and residential facilities, and a declining percentage going to the pharmacy, emergency department, and inpatient facility subcategories. The other category makes up approximately 7% of total commercial behavioral health spending, and based on the Milbank's methodology, claims are classified as other when they do not meet the definition for any other subcategory. Now let's look at the share of commercial claims spending going to mental health and substance use disorder in 2023 by subcategory. The distribution of spending by service category is very different for substance use disorder services than it is for mental health services. For substance use disorder, shown in the orange bar, spending is predominantly for residential and inpatient care, while mental health spending, shown in the blue bars, is concentrated in the outpatient, professional, non-primary care, and pharmacy subcategories. I presented a lot of information, so to summarize these, here are the high-level takeaways. The share of behavioral health claim spending as a percent of total claim spending in California's commercial market increased from 6.6% to 8.2%, or by a total of $2 billion between 2018 and 2023. Substance use disorder spending makes up roughly 11 to 12% of total behavioral health spending over the same period. Mental health and substance use disorder spending categories differ noticeably, while professional services and pharmacy spending make up a larger proportion for mental health spending. Facility spending makes up the majority of substance use disorder spending. So we have seen the charts, data, and the key takeaways, and let's move into the lessons learned. While the analysis showed clear patterns in spending, the process itself also highlighted an important lesson. Applying the Milbank's methodology places a substantial fraction of behavioral health spending into other services. By refining the technical specifications, we can minimize spending categorized as other services and gain a more precise, more actionable picture of where behavioral health spending truly goes. With that, I'll turn over to my colleague, Debbie.
Thanks, Ertug. OCA's presentation of this analysis to policymakers and stakeholders sparked quite a bit of discussion. It highlighted that we have more to learn about the drivers of the spending trends we've seen before we're ready to set an investment benchmark for California. Our plan to establish a benchmark this past summer has been postponed, pending further HPD analyses until at least 2026. I'll conclude with some thoughts about the impact this analysis will have on behavioral health work in our department and in our state. First, it's given us a look at recent trends in California commercial market spending on behavioral health services. This is the first time such detailed information is available for California, and it's an important application of the largest state APCD. Second, these analytic findings have already and will continue to inform HCI's work to measure behavioral health spending and set a statewide benchmark for investment in high-value behavioral health care, thus furthering HCI's strategic policy goal of increasing value in the healthcare system overall. Last, this detailed analysis of behavioral health spending can inform the work of public health professionals, policymakers, and others in California and nationally who seek a better understanding of the levels and distribution of behavioral health spending. We hope that our work will serve as a foundation for future analyses of the impact of behavioral health investment on access and health outcomes. We'll leave you with links to resources to learn about HCI, in particular to the HCI Behavioral Health Spending Data Brief, which is the public report of the findings we've presented here today. And now I'll pass it to our moderator, Sara Hallvik, so we can respond to your questions. Thank you.
Thanks, Debbie and Ertug. Really nice presentation, and I think a nice kind of build upon our first presentation to see some of the similarities and trends over in behavioral health use and spending over time. So I'm seeing in chat interest in a methodology question around NDCs and how you identified behavioral health conditions specifically. So I'm wondering if you could address Nate Pauly's question. How did you identify NDCs associated with behavioral health treatments?
Sure. Thanks, Sarah. I can take that one. And Nate, thank you. Great question. So overall, actually, the identifying behavioral health conditions before moving to the NDCs, identifying the behavioral health conditions, they were identified using the approach recommended by the Milbank Memorial Fund. And per Milbank's methodology, the behavioral health claims defined as those that have the primary diagnosis of the behavioral health condition, or that include mental health or substance disorder screening or assessment services, regardless of the diagnosis. And then to Nate's question regarding to prescription drugs, and then we used the National Drug Code NDCs with the behavioral health treatment, and we also used the Milbank's methodology for that. There's a list of NDCs, and I believe Julia put a publication in the chat, so those NDCs can be found there.
Great, thank you. And yeah, Julia, thank you for sharing the Milbank methodology information there. And if others of you listening have also used Milbank, I'd be interested in hearing about it in chat. Wondering if we could go to Chris Odell's question next. Ertug, did you divide spending by the number of claims or patients?
Got it. Did you divide spendings by the number of claims? We just get to aggregated level of the claims and their associated cost, total cost with the plan paid amount, and then also members' share cost. We didn't look at the number of the patients for this study.
Great, thank you. And for either one of you, Debbie or Ertug, I'm wondering, was there anything in your results that surprised you?
Yeah, sure, I can take that. So a couple of things surprised us. One was just we didn't anticipate the strong growth trend in behavioral health spending over the time period of the study, both in absolute dollars and as a percent of total claims spending. So when we discussed this with our stakeholders, though, a number of them were not surprised because they've seen increased utilization of visits, and in particular telehealth. And part of that may be driven by strong regulatory attention in California to mental health parity. yeah, so that was one surprise, and then another surprise was just how lopsided the distribution between mental health and substance use disorder is, with just a little bit over 10% of total behavioral health spending going to substance use disorder. We think some of that may be the methodology's reliance on the primary diagnosis on a claim, and there may be claims where both a mental health and a substance use disorder condition were addressed, but it will get assigned to a category based on whichever of those was the primary diagnosis.
Yeah. Was that surprising to your stakeholders as well, the lopsidedness?
Yes, it was a bit surprising to them as well. And this is commercial market, so that's one piece, that a lot of the substance use disorder treatment in California is covered by our Medicaid program, and so that may be part of the explanation. And we'll be doing a lot more analyses to dig into some of the reasons for that finding.
That's great, thank you. We're not seeing any other questions in chat. Shall we move on to our third presentation? Debbie and Ertug, thank you very much. And we'll bring you back to stage at the end for a larger discussion. Okay, so our third presentation follows a bit of a different format. This is called a point of view. So you'll be hearing from the One Utah Health Collaborative and from Comagine Health on the role of data in care coordination for mental health. Point of view. And take it away.
Hi, everyone. I am Bose. I'm the Director of Research with One Utah Health Collaborative, and I'm joined here with Cindi, who is our Comagine partner. Cindi, do you want to introduce yourself?
Sure. I am Cindi McElhaney. Like Shri said, I'm from Comagine Health. I am the manager of our analytics and reporting team.
Thank you, everyone. So today we will be sharing a point of view on Utah's breaking point of view on integration of behavioral health. We'll be sharing our perspective of how Utah has one of the highest rates of adult mental illness in the nation and some of the lowest access to care. So this mismatch, how it is leading to a need, capacity, and unsustainable position for Utah. So when people can't find care, they delay treatment, conditions are worsening, cost is rising, and the community is suffering. So this should be a breaking point or a turning point where we act together. So the problem, Utah's challenge is both clinical as well as structural. Of the 30% of Utahns who have identified that they have mental health need, 41% don't have access to care or don't know where to access care. That means nearly half of those who need help cannot find the front door. And when they come in, it's too late. People end up in emergency rooms, crisis centers, even in jails, settings that are costly and are ill-suited for this kind of recovery. Behavioral health spending is 5% of total healthcare spending for the state of Utah. So in short, Utah is paying for worse outcomes, a clear sign of a problem. So as I was saying, like Utah is using 5% of the total healthcare spending from the claims data we saw in behavioral health care spending, and it is more reactive than proactive, which is causing the outcomes to be worse for behavioral health and mental health. With support from the Comagine Health, we have examined the Utah's all pairs claims database and Medicare database from 2019 to 2023, and we have seen the prevalence rate and the cost of a person with behavioral health compared to one without. So for commercial plans, we saw 21% of members have a behavioral health diagnosis as a primary diagnosis and cost 1.7 times more. Medicaid, 27 to 30% of members cost 2.5 times more, and Medicare fee-for-service, 16% of members cost over twice as much as those without behavioral health condition. And you can see similarly for Advantage, 17% of members have behavioral health as a primary diagnosis with 1.8 times as much of cost in comparison to a person without behavioral health condition. So these numbers are saying that behavioral health drives cost across every payer, but it's receiving a fraction of the investment. So this is a misaligned system that we are seeing. The core problem, so our analysis identified when we spoke to our stakeholder, is there are a certain 4 different issues that came up. One was workforce shortage, particularly for psychiatrists and PCPs addressing mental health needs, as well as for rural health providers. There was payment misalignment, that means lower reimbursement and restrictions like same-day billing limits. It's a very fragmented system, that means electronic health records do not connect behavioral health with physical care. They don't talk to each other. And then also access and stigma, that means referral gaps, network inadequacies, and cultural stigmas where people don't want to go and seek help. So we cannot solve these through isolated fixes. We need aligned incentives, shared data, and connected workforce, focusing on prevention rather than becoming crisis response. So the collaborative's point of view is it needs to be more integrated. Payment reform has to happen. It has to be, the integrated system needs to be scaled up, and there has to be data interoperability working properly. There has to be aligned incentives, building workforce capacity, and connecting data across physical and behavioral health. That's how we will be doing better. Otherwise, we will be keeping on paying more for worse health outcomes. Cindi, do you want to give Comagine's point of view?
So I only have a couple of things to add to the presentation that Shri has done. One thing that I think is really important is a lot of data and reporting systems tend to treat behavioral health as a separate line item on their reports. I think this goes back to, just historically, behavioral health has been a separate benefit with a separate network of providers. It's really important to take an integrated view of behavioral health within the entire healthcare system and a patient-centered view. The example I always give is you have a diabetic patient who has issues with depression. They're not going to be managing their care well, and their costs for diabetes are going to increase. One of the really beautiful things about this analysis that One Utah Health did is they did do comparisons of people with behavioral health conditions to people who did not, and pointed out that the costs are higher. The other thing I would point out is, this analysis was done with APCD data. That's why we're here. We're all using claims data to do our reporting. It doesn't give you a complete picture of the care that's being provided. One example, of course, is depression screenings, which are captured in EHR. So I think looking for ways to include data that's not in to supplement your analysis is really important. Looking maybe at HEDIS measures around depression screening, or looking at survey results to capture information for patients who self-pay, just to make your analysis more robust. I think that's important. And then I'll turn it back over to Shri to wrap us up.
Yeah, so I would add another point with that analysis that we did. You can see that a person with behavioral health has so much more cost than a person without. You would say, like, yes, they have behavioral health problems along with primary physical health. That's why they are higher. No, we also saw that their physical health cost was also higher than a person without a behavioral health. So that was interesting. We didn't present those results here, but we have those results that we will be publishing soon. So that was interesting for us to see that a person with behavioral health was also costing more for physical health problems that they had. Here we saw, when we spoke to our stakeholders, where our stakeholders includes healthcare systems, hospitals, provider groups, all the payers, and all kinds of healthcare associations in the state of Utah. We have this a rich group of body that comes together and talks about these issues. There, where we agreed to start is we need to expand on the integrated care model, such as the collaborative care model that is out there, and embed mental health or behavioral health into the primary care. Also expand telehealth statewide. Reform payment systems, that is allowing same-day billing and supporting value-based bundle payment models. Invest in more workforce and technology. Utah is also already doing a lot in workforce for behavioral health. They're trying to increase the workforce there, strengthening the provider pipelines, and real-time EHR sharing. We all know there is a lot of things that we can do over there. And then last one is reducing the stigma that behavioral health is a part of the whole person care. I think we need to reiterate that to everyone so that that stigma is gone. Our call to action or the choice that we are talking here is it needs to be a coordinated, integrated behavioral health system. Utah can be an ideal state that shows how to do that. And if we keep on doing it as a fragmented system that everyone is doing, it's going to keep on costing us more and we are going to get worse health outcomes. But Utah has an opportunity to turn this around and make this crisis into a catalyst of integrated and accessible care. So as I have already mentioned these, for policymakers, advanced reforms in same-day billing, improved Medicaid integration, workforce reinvestment, for payers to align incentives. We have heard from several providers that the payment model is not working for them, for behavioral health providers. So there is a lot that can be done over there. Telehealth expansion and value-based contract, that those can be explored more. There has to be a scaled integrated model where aligning and expanding data sharing. Data sharing has been such an issue, no matter it's only in the physical care model system and like physical and behavioral health, that's another additional hurdle that we have to overcome to make it more integrated, and then destigmatizing and improving navigation. So I would like to conclude that we can bend the curve as well as just not in cost, but also in improving behavioral health outcomes, because we are not doing so great right now by taking action right now. So with integration. Thank you so much. Does anyone have any questions?
Thanks, Shri and Cindi. And yes, audience, if you do have questions, please go ahead and get them into chat for our presenters. So I love the way that your call to action built on the data that was shared by our earlier presenters, because the cohesive story is really coming together. We're seeing increased utilization, we're seeing increased cost, and we're seeing the continuation of a fragmented system. So Shri, I would love the first question to go to you, actually. At the beginning of the presentation, you called out access as a barrier for Utahns trying to get behavioral health services. And I'm wondering how the integrated care model that you include in your call to action would help address the issues of access that you called out first.
Thanks, Sara. So I would say like integrated behavioral health will actually help in expanding more access because there will be co-location of services. So having mental health services in your primary care location, that will give you immediate co-location of services will give you immediate access to that. So that's one way of resolving access a little bit easier. Then the warm handoff from your physician, physical physician, to your mental health provider, and getting the charts or getting your records flowing like in a better way, systematic way, will also help increase access. This will also, I think, in paper, I think, and technically will also reduce stigma. If your physician is actually helping you guide through that process in person, that might also reduce that stigma that I was talking about in our presentation. It will also help in scheduling because we know how difficult it is to get people. So that might also resolve the scheduling issues and getting someone in 6 months when they actually need the help right now. So I think this integrated behavioral health will probably solve these kind of issues and not have people show up in ER in critical form when you don't need the help that you should have gotten the help before.
That's great, thank you. And I'm curious either for Cindi or Shri, I know you make a pretty compelling case for the correlation between utilization and cost of physical health services and behavioral health services in your call for a more integrated model. And you had some action items for policymakers specifically called out there, but I'm wondering if you could say a little bit more about what do you wish policymakers would actually do with your data? What would you like to see happen? Oh, Cindi, you're muted.
I was on mute while everybody else was talking. So policymakers, I think they really respond well if you make an argument based on cost. That may sound a little bit cynical, but I think that they do. And I think sharing this information with them, that it's not just the behavioral health component, that it's all these other physical costs, would make a difference. And I think the other thing is emphasizing, I guess, touch points that primary care has a big burden. They're supposed to be tracking and monitoring a lot with their patients. Giving them the adequate resources and support to actually make those warm handoffs that Shri talked about, I think is really important. Using this data to convince policymakers to do that, I think is really key.
I would add, we are already doing this in Utah. Maybe other states are also doing, but simplifying licensing and credentialing process, not holding it just for like advanced level degrees, might reduce the burden and also have more access at lower level credentialing people, if that's possible, like for undergrads to help out with the basic necessity of screening and stuff like that. And the other thing is, if there is more, I know we are also already doing telehealth, but like telehealth improvement, if there is anything that they can do over there. And removing I think there is also issue with same day billing of our physical and mental health. So if that is something that the legislators take on, that might be helpful as well.
So a really nice bridge between what we see in the claims data at the end of the day and how those data are generated, and kind of the on the ground barriers that are impacting that.
Yeah.
Great. So one more question here. Thank you, Olga. For either of you, Shri or Cindi, could you say more about what Utah is doing to expand the workforce and any analyses you're doing or would suggest doing to support such efforts?
So our division of licensing, I think they have given lower level, so undergrads, the credentialing to see patients at a screening level, and they can start doing what you call billing. But there is a little bit of issue going on with payers. So I think we are trying to resolve that one, as far as I know. So that's what we have been doing. We are trying to give credentialing to lower level degree holders, which is not there always. And also, sorry, the other question was, so division of workforce, they're also doing analysis of because our utilization is very high on behavioral health. So trying to see if it's an access issue, if it's because there is not enough providers. So that kind of analysis they're doing, we are also doing it to see where the trend is, what is causing the cost to go up. And we saw it is utilization. So there is more need of behavioral health providers. That is what we are doing right now. And also we have our group of stakeholders who are coming up with the idea of what exactly will solve that problem. So that's at the point we are looking at collaborative care model or like ED utilization of critical behavioral health clients. So we are trying to see which one works and will help with improving outcomes and reducing cost. We don't want utilization to go down. We want critical care utilization to go down, just to be clear.
Yeah.
Yeah. Great clarification. Thank you. So I think, why don't we bring our other presenters back to the stage now? And we have a few kind of cross-cutting topics, cross-cutting themes that I would love all of your perspective on. So first, audience, thank you for taking our poll. Looks like 62.8% of you have worked with behavioral health claims data before. So great perspective, and I would be curious to hear if your experience has been similar or different to the experience shared by our presenters here. And also noting the Vinyak's comment about pharmacy claims, oftentimes they do not have diagnoses fields populated.
Right.
So just a caution for all of us not to rely on diagnosis to identify behavioral health treatments in pharmacy claims.
Yeah, so I would like to add there how we did our analysis when we included pharmacy was we followed the patient. If they had a primary diagnosis, so we followed if they had a pharmacy claims of a mental health NDC code. So that's how we were trying to add up the behavioral health spending and utilization.
Yeah.
Thank you. Bianca, I actually want to go back to you. There's a question from Kimberly Fox earlier on that we didn't get to. Did you do any analyses of behavioral health diagnoses or conditions that are driving increases in the use of behavioral health services?
So in this analysis, no, we didn't really include a component looking at the diagnosis on the claim. We have looked at it kind of just in an exploratory sense in our data before, and kind of we definitely saw kind of an underreporting of diagnoses in the claims, which gave us some caution with like relying on diagnosis codes, I would say. The rates were lower relative to what was kind of publicly reported when we were benchmarking. So, but it's certainly possible. I think other presenters on this session did use diagnosis codes, and I think that it is like important context to kind of understand, right, the drivers of use and spending. I think that's something I'm interested in looking at in the future, but yeah, wasn't included in this analysis.
Great, thank you. And Ben asks a question that we've all chatted about quite a bit, which is that we know that out-of-pocket or out-of-plan spending is a big issue when looking at behavioral health services, either because the providers don't accept insurance or because patients choose to pay out of pocket. All of you mentioned this in some way in your presentations. So wondering if you could provide a little more insight into that topic generally. And maybe Debbie and Ertug, I'll start with you on this.
Sure, thank you. This is a really important question, and HCI has recognized the importance of this question, has done some exploratory analysis using the Medical Expenditure Panel Survey household component, or MEPS, to try to measure this outside of insurance spending by consumers. We've run into some data limitations on that data source, mainly the small sample size when you take it down from a national to a state level. And so we're continuing to explore ways to use MEPS or other data sources to quantify this out-of-plan spending, which we all know is a big issue in behavioral health in particular.
That's great, thank you. Bianca, what would you add?
Yeah, I think MEPS is a good data resource to try to understand, kind of self-paid mental health use. I think a study that I was reading recently reported, I think it was just looking at the pediatric population, but it's somewhere around 25% of visits were, self-paid.
So an important chunk of missing data, we rely on claims only.
Yeah.
Cindi or Shri, what would you add?
Sorry, yeah. So we did 1,000 UTANs survey to understand how many people are not using insurance and going just directly out of pocket. And we have those results. Sorry, I was trying to find those results as you guys were talking, but that's how we were trying to have tried to capture the proportion of population that is not going through claims, but are going directly to their providers and using out-of-pocket cost. I think it's around 15 to 17% we saw, but I don't have the numbers exactly right now.
Yeah.
Yeah, that's great. And I think surveying the population is a really great way to understand how much you might be missing from claims only. Another question. Each of your analyses used a different methodology to identify behavioral health conditions, but I noticed that none of you pulled secondary or tertiary diagnostic codes. sticking on our potentially missing data conversation here, do you think you're missing claims not looking at secondary or tertiary? Or could you explain the rationale for the methodology decisions on that?
So for the prevalence rate, we did primary diagnosis, but we pulled secondary and tertiary for any diagnosis for our analysis.
Okay, so you did pull that in. Any others? Thoughts about the primary, secondary, tertiary diagnostic question?
Sure, I can speak to that from HCI perspective. When we're measuring spending, there are just many claims where there are multiple diagnoses and many different ways that providers choose to order them when submitting a claim. And so we are concerned about missing the secondary and tertiary diagnosis, in particular in the primary care setting, where oftentimes, as has been discussed here, providers are treating multiple different things at once. And at least in California, providers are often trained not to put the behavioral health diagnosis as the primary diagnosis, even when it is the main thing that was addressed in a visit. So we're concerned that we're missing spend there. But the trade-off is potentially a pretty substantial overcounting of medical care if we were to include claims, especially inpatient claims that had behavioral health as a secondary or tertiary diagnosis. We probably would capture quite a lot of medical spending. And so we felt like it was more important to make sure that our measurement of behavioral health spending is behavioral health spending and not medical spending. So right now we're sort of accepting that trade-off.
Yeah, interesting. Thank you.
Yeah, one thing I would add is, trying to design your analysis so it is patient-based instead of just summarizing diagnosis with your claims. That can help because what you do is you can identify a patient that has behavioral health diagnosis in their population. And then when you pull in the rest of their claims, then you can separate it sort of into the different categories and whether it's their physical health spending or their mental health spending.
Yeah, I was just going to add, we didn't include diagnoses in our analyses. So if anything, ours might be like a little over-inclusive, though we didn't really find many cases where a mental health provider was providing a non-mental health service. But I would just recommend if you are including diagnoses codes that maybe do a sensitivity check to see what the difference is with just primary versus a secondary and tertiary. Because like others have said, it can really sometimes drastically change what your your spending and utilization looks like.
Great recommendation. Thank you. So I'm curious where you all are going from here. Like what is the next step in your analyses, or how are you moving from data into action, or are you doing anything to answer One Utah Health Collaborative's call to action? Anybody can go first.
I can go first for HCI and what we are doing. So currently, actually, we are in the process of analyzing the spending share of specific diagnosis codes, revenue codes, place of service codes for the certain subcategories we discussed in our presentation, and then the other bucket, which was about 7% spending going in the other bucket. Hopefully, like identifying those, the findings from all the analyses will be used to improve hopefully the technical specifications, and more specifically help out our OCA partners, in what includes and excludes from their behavioral health code set that will be used for measuring behavioral health spend at the payer level. And information on top spending and diagnosis may also influence future conversation on the behavioral health benchmark. As far as kind of data portion, that's what kind of next steps.
That's great. All right, I think our music is playing. So Utah team or HCCI, if you have, I'll give you 30 seconds, Norm. Can we do that?
Yeah.
Final comments.
But no more.
I can just jump in that I think as a research organization, we're just trying to continue to contribute to the body of evidence that mental health services are important and are in demand. One of the next analyses we're working on will include more services, so pharmaceutical claims, and we'll also include primary care providers to look at their role in providing mental health services as well.
That's great.
Okay, well, thank you, everyone. This has been a fantastic opportunity for us to hear from you about a very important topic. For those of you who are able, we're going to let you know that the next thing up are our networking sessions. They'll start in about 10 minutes at 2:20 p.m. Eastern, including just a kind of a last-minute ad. Julie Saunier from the early morning panel has opted to do a networking session if you want to ask her interactively questions about TIC data and hospital price transparency. But the other sessions are fantastic too. Please join one of those sessions and make new friends, network, and grow your network, if you will, of your expanded circle of friends. But thank you, Sara, for organizing, and thank you for moderating. Thanks, everyone, for your time, and we will see you again soon at another session.
Thank you.
Thank you.